It's a little hard to teach bipolar disorders without teaching major depression as well, because they go together, but they are not in the same section of the DSM-5, so they're taught separately. Nice thing for you is once you learn about the bipolar disorders, it'll make it easier to learn about the depressive disorders, or the other way around. Once you learn about the depressive disorders, it's easier to learn about the bipolar disorders. Bipolar disorder, you want to focus on mood episodes. And so one of the things about bipolar disorder is it not someone who just has mood swings, someone who can go from being depressed to being elevated. Remember, we're looking at disability and distress. And so for the manic episodes, we're looking at an extended period of time when a person feels abnormally. And that's the key word here: elevated, expansive, irritable, or depressed. And so those are your mood episodes, how you define them. So, of course, the manic will fall in the first three. Elevated, such as a feeling of euphoria, feeling very up. Expansive would be extreme expressions of emotion or behavior, such as feeling superior or grandiose. Irritable, but not situationally based. So this is not, the neighbor's dog keeps on barking and it's bothering you. This is just ongoing irritability. And again, depression, not situationally based. Now, again, life happens and we get depressed from time to time, but this is a type of depression that keeps on going on when you don't really have a reason for it. And so those are your major building blocks to your bipolar disorder: major depression, mania, mixed, and hypomania. And depending on how the person manifests will depend on what you put together. So it's a pattern of illness due to abnormal mood. And always think in terms of distress and disability and duration. And this is particularly important with bipolar disorder because you have to specify whether this person is mild, moderate, or severe. And so again, as I said on the previous slide, we all experience depression and we all experience euphoria. These are exceptional, over and above what would normally be considered for normal responses. And as usual, we want to make sure that we rule out the differentials. And so, to be honest with you, if you want to know what bipolar 1 disorder looks like, pay attention to someone who is abusing cocaine or methamphetamine. Because you have someone who gets very elevated, expansive mood, feels like they can accomplish anything. And then once they come off of the cocaine, because what they've done to their brain chemistry and the depletion of their catecholamines, they fall into a deep depression. You'll see the same with methamphetamine, ecstasy, most of the stimulants. And so that's one of the reasons why you have to rule out a substance use disorder and other medical conditions, because those symptoms will remit once the medical condition is cleared up or if the person stops using the substance. So this chapter is divided into bipolar disorders and other related disorders. You do have the depressive episode criteria listed, which you will learn in the depressive disorders in the next chapter in the DSM-5. You also have the specifiers and the level of severity. So as far as bipolar disorder is concerned, if you read in your book, you'll see it's more common in high-income countries than low. And you always have to ask, are people experiencing it less frequently, or does it have to do more with having enough money to identify who is experiencing bipolar and who isn't? There looks to be a genetic component, so that bipolar disorder runs in families. The suicide rate is 15 times greater than the general public, so you always have to be concerned as far as someone's personal safety. And there's a high rate of co-occurring disorders. You actually do see substance use disorders with people who have bipolar 1 disorder, and it kind of makes sense if you think about it, especially when you're in the manic phase and you're doing activities that might be considered dangerous or harmful. Well, there's not much more dangerous or harmful than doing an illegal drug. As far as coding bipolar disorders is concerned, you always have to identify the most recent episode. Since you've got the word bi in there, which means 2, you have to specify the person you're seeing. Are you seeing them in the manic phase, or are you seeing them in the depressive phase? I get to this later on, but more than likely you're probably seeing them in the depressive phase. One of the biggest challenges with bipolar disorder is people like feeling the mania. And so they don't usually seek help when they're in the manic phase. What does it say on one of the earlier slides? You feel euphoria. Euphoria feels really good. So why would you seek help when you feel good? And so you definitely have to specify the most recent episode. Is it manic, hypomanic? Well, for bipolar 1, it wouldn't be hypomanic. Is it depressive? You have to identify the severity. Is it mild, moderate, severe with psychotic features? You identify the features, and there are a lot of them. And the ICD code is always 31. So 31 will always be the first 2 numbers for the bipolar 1 disorder. What comes after the decimal point identifies the episode, severity, and features. So if you have bipolar 1 disorder, moderate, and the current and most recent mood is manic, then it's 31.12. And so the 1 indicates that it is moderate, which, if you have bipolar 1 disorder and the most recent episode is depressed, then it's 31.32. Sorry, I got confused there for a second. Sorry, the 1 indicates it's a manic episode, the 3 indicates that it's a depressive episode, and the 2 indicates that it's moderate. So 31.1 means that it's bipolar 1 and the most recent episode is manic. 31.3 is bipolar 1 and the most recent episode is depressed. Where the 2 comes in is in both situations, it's moderate. So if it was mild, instead of being 31.12, it would be 31.11. And if it wasn't moderate but mild, it wouldn't be 31.32. It would be 31.31. And so if you can just remember that bipolar 1 disorder is always 31, and the numbers that come after the decimal will specify which it is, a manic episode or a depressive episode, and whether it's mild, moderate, or severe, then you'll be ahead of the game. Now, the interesting thing about the specifier with psychotic features is psychotic features are always considered severe. So you don't even code the severity because it's a given. So bipolar 1 disorder 31.2, most recent episode manic with psychotic features, you'll see only has one number after the decimal. And that's because, as I said, you don't have to code the severity. Same with 31.5, bipolar disorder, most recent episode depressed with psychotic features. Again, you do not have to code the severity because we already know, because you've got psychotic features. Historically, I've written severe. You don't have to. That's up to the clinician. It's not part of the code. Now, you might be confused as to what's the difference between bipolar 1 and bipolar 2. And probably the easiest answer is you know it when you see it. Bipolar 2 is not as debilitating. And so what you're looking at is the duration and the disability as far as guiding us. And really it is the disability, because you can actually have the depressive episode, still has to be 2 weeks. So what you're really looking at is the hypomanic episode for bipolar 2. Now, in the case of bipolar 1, you have to have a manic episode of at least a week unless you're hospitalized. So, for example, I once worked with a woman, this was when I worked in the psychiatric hospital, who was pulled off the Pennsylvania Turnpike, which, think about the 285 around Atlanta. Yeah, that was the equivalent to what she was doing. Is she was on the Pennsylvania Turnpike, standing in the middle of the traffic, trying to perform a magic trick. She was taken into custody for her own safety and brought straight to the hospital. It's been too long since I've worked with her, but you know what? It doesn't matter if she had only been manic for 2 days, because she was so severe and had psychotic features that it didn't matter. Once she was hospitalized, it was considered a manic episode because of the disability. Remember the D. When you're talking about bipolar disorder, the disability and distress that it causes is going to be probably your biggest guide as to whether it's a manic episode or a hypomanic episode. And so if it's lasted a week, you're probably looking at bipolar 1, but not necessarily. If the manic episode has lasted 4 days without hospitalization, you probably need to look at bipolar 2. But again, not necessarily, because we're still looking at disability and distress. Wait, what? Okay. So when you're doing an assessment, you may not know right away if an episode is manic or hypomanic because you just met the person. And so figuring out the duration and the disability are crucial. if the person is hospitalized, like the example I gave of the woman who was doing a magic trick in the middle of the Pennsylvania Turnpike, you're looking at bipolar 1 and probably with psychotic features. That's what led to the hospitalization. Whereas with the bipolar 2, you don't ever see hospitalization. For the most part, they're functional. They may be struggling, but they're functional. They can get through their day. They may not sleep well. They may be causing problems at home or at work, but the level of disability is not so high that it is impairing their functioning to the point that they have to have hospitalization. Now, as far as the major depression goes, good thing to remember for bipolar 1 and bipolar 2 is it's exactly the same. With bipolar 1, you actually do not ever have to have a major episode of depression. One of the things that was considered when they wrote the DSM-5 was going to a unipolar diagnosis because it seems silly to call something bipolar if you never saw a depressive episode. Why would you call it bipolar if they're only seeing half of the bipolar disorder? But they didn't do that. And so you have to have the major depressive episode for bipolar 2, but you don't have to have it for 1. And so if you can remember this criteria for bipolar disorder, then you will be ahead of a game for major depression because it's exactly the same. And so you just have to have 5 or more of the following, but you must have either a depressed mood or loss of interest in pleasure. So those have to be 1 of the 5 and 4 of the others. So depressed mood, diminished interest, significant weight loss or gain, insomnia or hypersomnia, psychomotor agitation, fatigue, feelings of worthlessness, diminished ability to think, and recurrent death thoughts. Not all of them, just 4 plus either depressed mood or loss of interest in pleasure. And as I said, the major depressive episode is not required for bipolar 1. You also want to make sure that they don't meet the mixed episode criteria, which is in the back of the bipolar section. Again, you've got to have significant distress. And the differentials, if not substance-induced, can't be accounted for by bereavement. And if there is no manic or hypomanic episode, it's not bipolar 1 or 2. You're just looking at major depression. Now, as far as the manic episode goes, and this is only for bipolar 1, abnormally and persistently elevated, expansive, or irritable mood lasting 1 week or any duration if hospitalized. So there's your D in duration. Has to be at least a week. If it's under a week, you're going to have to diagnose hypomanic. Unless it's got hospitalization. Symptoms include 3 or more of the following, and 4 if it's irritability. So if you don't have someone who's elevated or expansive, but they're irritable, then they have to have 4 of the criteria, not 3. And that would be inflated self-esteem, decreased need for sleep, more talkative, flight of ideas, distractibility, increased goal-directed activity, which may sound good, but if your goal-directed activity is to perform a magic trick in the middle of the Pennsylvania Turnpike, that's abnormal. Excessive in activities with a high potential for painful consequences. So you may have someone who's always been faithful to his girlfriend who suddenly starts having unprotected sex during a 4-day period with, several different women, spending money that he doesn't have and driving at outrageous speeds that at other times he doesn't do. And that's where you have the caused marked impairment, which is your distress, and disability. And this isn't due to the fact that he's been using cocaine. It's not due to substance-induced or medical reason, which is your differential. And really, again, for all of this stuff, you're really looking at distress and disability. All of us have the potential of doing silly stuff. All of us have the potential for doing stuff that we know is not the best idea. All of us have mood swings or periods where we're really up and excited and stuff like that. That's not necessarily a manic episode. We're looking at distress and disability. Always keep that in mind. And you really need to familiarize yourself with the specifiers on pages 149 to 154 because they fill out the picture for the person you're working with bipolar disorder. So does the person have anxious distress? Is it mixed? Is there rapid cycling, meaning that they bounce back and forth between mania and depression? Do they have melancholic features, which would go with the depression, and atypical features, which would go with the depression? With mood congruent with psychotic features, does the mood connect with whatever the psychosis is? And so the woman who was directing performing a magic trick in the middle of the Pennsylvania Turnpike, her mood actually made sense with her psychotic features. Sometimes you will not see that. You will see the mood that does not follow with the psychotic features. It just two polar opposites. Catatonia, again, you'll see that with the depression, not with the mania. Peripartum onset, that means either during pregnancy or after birth. And with seasonal pattern, which means you only see this at certain times of the year. Again, I really would suggest you go through and just read these and just try to get a mental picture of what they look like, because it'll help you down the road when you actually have to use this information. Some of it you'll see again with depression, like the melancholic features, atypical features, catatonia, peripartum onset, and seasonal pattern, because we have realized that there are some consistencies we can pay attention to that'll help us get a full scope of understanding of what the person is dealing with. Now, as far as the recording procedure goes, you need to write the name of the disorder. Then even though the code tells you all the information, you still write it out. So it's the name of the disorder, the specifier coded most recently as the episode either manic or depressive. The specifier coded as either mild, moderate, severe, or with psychotic features. And then you have the specifiers that have no codes. I have a tendency to write it backwards. Be honest with you, you really won't get in any trouble unless you have a supervisor who's particularly rigid, because all your billing people worry about is the 31.13, which tells them that it's bipolar disorder, most recent episode manic, and then it's severe with anxious distress. Sometimes I will write bipolar disorder, severe, most recent episode manic, as I said, that's not going to bother your billing company because it's coded right with the F31.13. So you may have a supervisor that will make you change that. The difference is, and moving over to bipolar 2 disorder, really the main difference is the hypomanic episode is not manic, and there must be a depressive episode. It's not required for bipolar 1. Since bipolar 2 does not come with the same distress and disability, you have no severity specifiers. Really, what you're doing is, if you can't decide between bipolar 1 and bipolar 2, then what you're really saying is, I can't decide between bipolar 2 and bipolar 1 mild. And again, it's the distress and disability that's going to dictate that, because you may have a hypomanic episode that lasts a week, but the distress and disability are not the same as bipolar 1 mild. So for bipolar 2 disorder, you only have one code to remember, and that is 31.81. Even though you will have your DSM-5 available at all times, you actually will probably memorize 31.81. Not that you see that many people with bipolar 2 disorder, because since there's not as much distress and disability, a lot of them will learn to just live with it. And you specify the most current episode, and if needed, anxious, distressed, or mixed. So you have bipolar 2 disorder, most recent episode, hypomanic, as opposed to bipolar 2 disorder, most recent episode, depressive. Keep in mind, the reason most people with bipolar 1 or 2 disorder seek help is for depression. This is why it is crucial that you have or you conduct a thorough evaluation, because it's really not a good idea to put someone with bipolar 1 disorder on an antidepressant, because it'll work great for their depression, but then when they get into the manic phase, that is not the manic medication they need to be on. And quite frequently, especially from what I've witnessed with bipolar 2 disorder, the depression can be really debilitating in bipolar 2 disorder. Again, that's not scientific, that's just my personal experience. So, collaboration is very important. If you can get medical records, if you can get previous assessments, or if you can talk to a parent or a guardian or a spouse or someone to make sure that the person you're working with is really a major depressive episode and not a major depressive episode when he or she's also experienced either a manic or a hypomanic episode. Treatment is important, and you got to get treatment right. Cyclothymic disorder is not as common and a little harder to describe. Essentially, what cyclothymic disorder is it's a person who has some criteria for a hypomanic episode, some criteria for major depression, but not enough for both. But they do have distress and disability. And they don't have the criteria for a differential. So they have a constant mood fluctuation with some hypomanic symptoms and some depressive symptoms. And so for that coding, it's always just F34.0. You can have with anxious distress if necessary. Here's where it's very important. Duration is the most important thing to me when diagnosing psychothymic disorder, because seriously, the criteria is essentially not enough information to diagnose with bipolar 1 or bipolar 2, but they do have, distress or disability, but not horrible distress and disability. So this is someone who has more than just mood swings. You're looking at least 2 years of some manic symptoms or hypomanic symptoms, some depressive symptoms, but not enough for either. That's what we call a pervasive pattern, and that's when you would diagnose cyclothymic. I've met a couple people who are diagnosed cyclothymic. I've never actually worked with someone. One of them actually had a thyroid problem that wasn't properly medicated. And so her cyclothymic disorder actually was not accurate. It was due to another medical condition, because once she got the thyroid condition taken care of, her cyclothymia remitted. The other person, it seemed as though she was probably diagnosed correctly. And she had some of that, those periods of high energy, high motivation, get things done. But then she would slip into periods of depression, but they weren't debilitating. They felt more like the Monday morning blues that went on a little bit too long. And then she'd fluctuate back into these periods of high energy, and sometimes she'd do stupid stuff that she just couldn't understand why she did it, but not anything really crazy over the top, just stuff that maybe an adult might stop and say, why did I do that? I don't understand why I did that. And so she was diagnosed with cyclothymic. I'll be honest with you, I honestly do not know if she met the criteria for cyclothymic, because she wasn't a patient of mine. I would have wanted to rule out attention deficit disorder and maybe a depressive disorder, because I'm just wondering if sometimes what she was doing wasn't so much elevated mood or stuff like that, as much as just being easily distracted and not thinking through her actions, which might put her in the differential of attention deficit disorder. But you know what? I don't know. And that's one of the reasons why evaluation is so important, doing a good one. As far as the other related disorders in the DSM-5, you won't be able to make those diagnoses without outside help, because you need lab work and or medical evidence. And so I usually don't test too much over related disorders, because again, the diagnosis is never going to fall on you exclusively, because you have to have confirmation from either substance use or a medical condition or something like that, or some substance induced. And again, if you look at the criteria, lab work and or a physical or something like that is required as part of the diagnosis. Look through the specifiers. As I said, they're on 149 to 154. They give you a more complete picture. And as I said, try to picture the difference between someone with bipolar 1 disorder, anxious distress, compared to someone who has a seasonal pattern and rapid cycling. read the criteria, and you'll see why the specifiers are so important, because they will manifest very differently. So, for example, with the seasonal pattern, you'll notice that it's primarily in the winter that we see some problems with this. Whereas with the rapid cycling, you don't see consistency with one mood episode. It's going back and forth between episodes.